Well, thank you very much, and thank you for inviting me to come to talk today. It's always a pleasure to come and talk with colleagues in other specialties about metabolic medicine. Um, I have a 30-minute slot, which provides me with rather a challenge in a way, because there are a lot of metabolic conditions and they can present in a very wide set of clinical phenotypes. Um, I've taken this diagram from the ICIMD website, and this is the sort of agreed international classification of metabolic disorders. And this sunburst plot essentially just shows the different categories of disorders that can affect the cell. And these are from fat metabolism problems, protein, cell trafficking, all sorts. And within this plot, there's a total of 1,462 metabolic conditions currently, and that's ever growing. So thinking about how to condense that into 30 minutes to make it sort of something useful. I've got a few slides just introducing what we really mean are inherited metabolic diseases and trying to put them in some kind of basic classifications. But the main part of the talk is really, I thought about a few things that we commonly get asked by our neonatal colleagues. So when they ring up and say, could this baby be metabolic? And I've broken that down into three sections. Firstly is the sort of sick, collapsed neonate, which I think I'm going to spend most of the time talking about today, and more really about recognition and picking these children up rather than the specifics of management, although we will touch on that briefly. I'm also going to talk very briefly about children who present with seizures and epileptic encephalopathy, and have a very brief slide on hypoglycemia. I may end up skipping over a few of the slides at the end because I suspect I will overrun slightly. And I've also got a slide just thinking about how we nowadays think about rapid diagnosis in these children, both for biochemistry and genetics. So I've been asked to make sure the audience do some work today as well. So we've got a bit of a Slido poll asking you how you feel about recognizing metabolic disorders. So I'll give you a few moments just to reply to that. I can see a pattern emerging here. So that's great. There's clearly a variety of replies. And I think it is quite understandable in a way that there's some anxious replies because, these tend to be conditions we don't come across terribly often. And I hope this talk may in a little bit make some of those emojis slightly smaller after this half hour. Fingers crossed. So how do we define? This probably won't help. This talk is not going to be about lots of pathways. I do put a few pathways up. The nuts and bolts of the pathways aren't important, but it is important to think about what we mean by inherited metabolic disorder. And actually, it's becoming much more gray in the area of whole genome sequencing. We're getting lots of new diagnoses, and it can be quite difficult to define what inherited metabolic diseases are. The sort of classical principle is essentially you have a pathway, a metabolic pathway within the cell where one compound A gets turned into compound D by a variety of steps. And if one of those steps is not working, i.e. you have an enzyme deficiency, the cell can have a problem. And this is either because you have an excess of a compound before the block, as you can see here, compound B, and that can intoxicate the cell, or you can have a lack of compound further down the pathway, which, for instance, can mean the cell doesn't have enough energy. And in reality, quite a lot of our conditions, it's probably a mixture of the both. There are lots of different ways of defining and grouping metabolic disorders. One of the sort of biggest groups, or the bigger groups to define them as are these. So intermediary metabolism is essentially metabolism of small molecules. We're often talking about energy metabolism. Complex molecules, larger molecules, either building them or degrading them. And also there are a variety of conditions where the cell can't transport molecules or ions. So they do provide a good clinical challenge, which is one of the things that attracted me to metabolic medicine. They are individually rare. So I'm sure people have heard of conditions like MCAD and PKU. These are our most common conditions and have an incidence of around 1 in 10,000. but the majority of our inherited metabolic diseases we've been talking about today are much rarer, typically 1 to 50, 1 to 100,000 births. But because there are so many of them, the general overall incidence is relatively common. And depending on how you define a metabolic condition, this figure changes quite a lot, but something in the range of 1 in 800. So you will be coming across these conditions regularly in neonatal practice. Now, what also makes them challenging, and especially some of the conditions we're going to talk about today, which make neonates acutely unwell, is they often present initially, at least, very non-specifically. So these might be babies who are start with feeding problems, bit of lethargy, bit of vomiting. And unless you think about metabolic and think about some specific investigations, you may not diagnose these children very quickly, which brings us to the last point of the slide, is that the prognosis for some of these children is very dependent on how quickly we diagnose and start some treatment. So this is my last slide by way of introduction, and I've lifted this straight from one of the metabolic textbooks, but I find it quite useful because it breaks up our metabolic conditions into categories, but also thinks a bit about when they present, which is obviously very relevant for today, thinking about the neonatal period. So in a way, the most important group is this group at the top, the intoxication, which we've already mentioned. Certainly the cases we'll talk about in a moment are mainly in this intoxication group. And essentially, these are children that can't manage a certain substrate, often say protein. When they're in utero and attached to the placenta, they essentially have their own hemofilter, so they manage fine. They're born, they come away from the placenta, and a toxic metabolite builds up, and they're also given the substrate, i.e. milk and protein. So they're often well for a few days and then will present with symptoms. And that's, we can see represented here by a peak in presentation here between 0 days and 1 week. Some of these children have milder conditions, may actually make it through the neonatal period, and then they tend to present here later on when they have their first illness and extended fast. There are also a number of conditions which children cannot make energy normally or use fat, for instance, for energy normally. And these children have a reduced fasting tolerance. Many of these children present after the neonatal period because neonates are generally fed pretty regularly. So these children tend to present in the neonatal period if they have other stressors and fast longer than normal. The next section here is disturbed energy metabolism. The typical conditions here are sort of mitochondrial disorders where the cell fundamentally cannot make energy well. So the severe conditions when babies are born, organs that require plenty of energy, brain, heart, liver, all run into problems very quickly. And a lot of these children, sadly, there are not very many effective treatments and don't do very well. The complex molecules we mentioned briefly, the classical ones here, the lysosomal storage disorders, where you can't break down complex molecules properly. They rarely present in the neonatal period. They present later on as the complex molecule accumulates in the cell and causes problems. The conditions where you cannot build some complex molecules, such as the peroxisomal disorders and congenital disorders, glycosylation, can present with multi-system problems in the neonate. And the last category is disturbed neurotransmission. And we will talk a little bit about this in one of the other slides. This is where essentially brain chemistry doesn't work. These children often present very early on with a sort of neonatal encephalopathy and seizures. So going through to really the more important bit of the talk is thinking about these three categories. And I'll start with the sick neonate. So this is a very basic clinical vignette of a child who presented to us a few years ago. I put the Slido sign here because just for a forewarning, the next slide is a quiz. So this is one you have to pay attention to. So this was a 3-day-old baby who was on the postnatal ward, still on the postnatal ward because mum had had an elective cesarean section, but there was nothing significant in the history. The neonatal team were asked to review the baby because of poor feeding. And they listed this history of 24 hours of poor feeding. The baby was now looking irritable, was vomiting, and was also tachypneic. So the child was brought to the neonatal unit for further assessment. And this was the initial gas. So I'll give you a couple of moments to have a look at it, and then we'll move on to the quiz. So the question is, what is the most relevant next investigation? And all of these, you could argue, are potentially very relevant for a child presenting like this, but in the context of this talk, what single one would you measure next? Excellent. We're getting an obvious leader at the moment. So I'm not going to talk about the answer to this now. We're going through a few slides and I'll come back to this case at the end of this section. We've got lots of replies and we've definitely got a front runner, which is great. So I did promise not lots of pathways. Again, the nuts and bolts of this aren't important, but just to outline the conditions we're going to talk about in the next few slides. We're going to talk about fat oxidation disorders where the cell cannot use long chain fat and make energy from it. We're going to talk about the organic acidemias and ureacycle defects as well. And these are both conditions where you cannot metabolize amino acids, i.e. protein, normally. I've also got carbohydrate here, which of course is a very important energy source for cells. We will mention these very briefly in the hypoglycemia section, but as mentioned already, babies who are fed pretty regularly don't often present with these disorders until they're a little bit older, and the natural space between feeds increases. So, firstly, the organic acidemias. So these are all conditions that involve the pathways breaking down your branch chain amino acids. So this is leucine, isoleucine, and valine. And these amino acids are essential. You don't make them. So these pathways become particularly important if you take on excess protein through the diet, i.e. milk if you're a baby, or if you become catabolic, because these pathways are very important in making energy, and babies will break down their own protein to release these amino acids and use them for energy. So both feeding and metabolism will mean you use these pathways a lot. And if these pathways don't work, that causes a big problem. And the three main conditions which cause the classical organic acidemias are isovaleric acidemia, propionic acidemia, and methylmalonic acidemia. And these three all tend to present fairly in similar fashion. They all have milder forms that can present later on in life, but the classic forms present early on, and these are intoxicating. So again, babies are generally born well. They're generally well for a few days. They feed and they start becoming intoxicated, and they present, again, non-specifically initially with encephalopathy. The key biochemistry to recognize these children is they are significantly acidotic. So they will have a large anion gap because of all the excess iron, and they will get a progressively worse acidosis. These children will also have high ammonias. So normal ammonia in neonate is generally quoted as under 100 micromoles per liter. These children, when they're sick and decompensating, will often have ammonias which are fairly high. 500 is typical. They can be quite a lot higher. And the other key thing to recognize is they will be very ketotic. Now, neonates tend not to be very good at making ketones. They can, but they don't tend to make many. If you're making enough ketones to spill out into the urine and be ketonuric, that is unusual and should make you think of organic acidemias. If we get called about one of these children suspecting organic acidemia, there's a way we try and find out, sort of diagnose these children accurately. We have a rapid metabolic screen, which I may have time to talk about briefly at the end, but also our standard metabolic tests. You will have come across organic acids from the urine, acylcarnitines, and plasma amino acids. The key exception to this to be aware of is a condition called maple syrup urine disease, or MSUD. This is sometimes termed a cerebral organic acidemia, and these children will present similarly in the sense that they will often be well for a day or two. The particularly bad, the bad guy for MSUD is leucine. So this will become very high relatively rapidly, and this is cerebrotoxic. These children will present again with lethargy, vomiting. They'll often be mistaken as having seizures because they'll have abnormal movements, typically cycling of both arms and legs, but they will often not be significantly acidotic, and they will often not have a high ammonia. So these guys are they don't scream metabolic so much. So if you've got a child with increasing encephalopathy, always think MSUD. It's the key thing if you're concerned about this, chat to metabolic team. We would need to measure a leucine quickly, which again, that is part of your standard amino acid testing, but you won't get that done in most centers very quickly unless you talk to a metabolic team and flag this up as a possibility. These children often have quite an unusual smell, hence the name maple syrup. It's quite a sweet smell. And classically, you can smell if you get an earbud and take a little bit of earwax, and you've got a good nose. That can also help get a diagnosis. So moving on to the urea cycle disorders. So these are all disorders where your urea cycle isn't functioning, and your urea cycle is key in how the body gets rid of ammonia, nitrogen specifically, but in the form of ammonia. And again, the nitrogen in ammonia comes from protein. And for a baby, that means the protein in milk or the protein from your own protein stores if they're allowed to become catabolic. And normally your urea cycle would manage that fine and keep ammonia in a very narrow range. If your urea cycle isn't working and you have excess nitrogen, your ammonia can go up very quickly. And ammonia is very irritant to the brain and needs to be recognized quickly. So again, these conditions, similar to organic acidemias, typically present in the first week of life. As that ammonia starts increasing, the baby's come away from the placenta, is being fed protein, and the ammonia creeps up, and then will rapidly increase. And at that point, children are looking very encephalopathic. And what's key to recognize is an increasing ammonia. It's a respiratory stimulant, so it'll make children tachypneic. And the typical blood gas is, initially at least, is a respiratory alkalosis. These children tend not to become acidotic unless they get to the stage where they are having apneas and seizures and having a secondary acidosis. And the ammonia can become very high very quickly and often gets into the thousands. And again, diagnosing these, the key to diagnosing these is recognizing it might be high ammonia. Once we've got a high ammonia, the initial treatment's the same, whatever the diagnosis, but we can try and pinpoint exactly which enzyme is wrong by looking at the different metabolites. I'm not going to talk about fat oxidation disorders in any length. This diagram essentially shows that the cell makes energy from long chain fat by moving it into mitochondria and going around a cycle of beta oxidation, which slowly shortens the fat, releasing energy each cycle. Now, there are a lot of different enzymes within the cycle, some of which work on long chain fat, some of them work on shorter chain fat, and they all have terrible acronyms like LCHAD and MADD and VLCAT. The bottom line is that it's the conditions that have the long chain fat disorders, which can't start to use fat for energy, which often cause a fundamental problem very early on. So they're the ones that tend to present in the neonatal period. As with many of our metabolic conditions, there are milder forms that can present in adulthood, but when they present in the neonatal period, the cells basically are struggling to cope with energy per se. So they have a multi-system presentation. So these children are often encephalopathic. They do have an acidosis, but what puts them apart from, say, the organic acidemias we were talking about is that these guys can't make ketones or rarely make many. And that's because ketones come from fat oxidation. So these will be a non-ketotic acidosis, generally with a high lactate. They often have a mild hyperammonemia. They often have hypoglycemia when stressed. And again, we talked about multi-organ function. So liver dysfunction, they can have muscle involvement with rhabdomyolysis. And for some of these children, cardiomyopathy can be a real problem, and that can be life-limiting. Again, we look at metabolites to get an exact diagnosis. I've mentioned MCAD at the bottom. So MCAD generally isn't a problem in the neonatal period. It is screened for in most countries, and it is generally thought of as quite a benign condition, because once we know a child has it, they will do very well, as long as we don't let them fast too long into current illness. It is important to be aware, though, that these children can present prior to the screening results. So in the UK, we screen at day 5. We would generally get a result when a baby's 10 or 11 days old. And it's not uncommon for a child with MCAD, especially a breastfed child, to fail to establish feeds and present quite unwell with their MCADs. So I'm not going to talk much about the management, because a key thing is recognition. But the basic steps to initial management of all these children is firstly to stop the toxic substrate going in. So from the point of view of the organic acidemias and urea cycle defects, that's stopping protein. From the fat oxidations, that's stopping fat. These children often aren't being fed because they're very sick. So that's not often a problem. but if it's recognized early when they're still feeding, that's very important. The next step is promoting anabolism. So this is trying to stop the child using the pathways that don't work. And we do that by giving plenty of dextrose. And certainly in the neonatal period, we like to give a generous amount, typically 8 milligrams per kilo per minute. And when they're unwell, if we can give insulin as well, that's very helpful because that's an anabolic hormone. The next step for high ammonia is giving some nitrogen scavengers. These are intravenous drugs that give the body an alternative route to get rid of nitrogen, which can help the ammonia. But the bottom line is we need to recognize these children quickly, liaise with your local metabolic service, because many of these children will need transferring to an intensive care setting where they can be hemofiltered. And the hemofiltration has two roles, really. Firstly, to directly reduce the toxic intermediate, which might be ammonia, which might be leucine in the case of maple syrup urine disease. It may help offload the acidosis, especially in the organic acidemias. And it also gives us a window to make sure that we can make that child anabolic. So give them plenty of the right type of energy so they're not using these pathways anymore. And that will hopefully get them on the straight and narrow. So coming back to the case, the key thing to recognize, which I think a lot of you did, which is fantastic, is that this is quite an abnormal gas. It's a respiratory alkalosis. This is an tachypneic baby. So the tachypneic baby may be because of a metabolic acidosis, it's blowing off, but this is obviously not the case. And this is because the child had a very high ammonia, making it overbreathe. So this was a boy who got brought to the neonatal unit. This was recognized very quickly. And ammonia measured initially was 1400. So this is very high. This is a medical emergency. And he received IV energy, scavengers, and was on a hemofilter within 3 hours. And despite getting onto a hemofilter very quickly, ammonia was 3000 before going onto the hemofilter. This is a very high ammonia, which is really worrying. And this is a little boy who turned out to have our most common urea cycle defect, OTC deficiency. His outcome was actually pretty good. He survived the initial high ammonia. He went on to develop relatively well. He did have some mild learning difficulties, and he ended up getting a liver transplant to treat his OTC at the age of 1 year. Sadly, this is not a common outcome for these children. A lot of these, well, the mortality for children presenting with high ammonia in the neonatal period is around 30%. And the vast majority of survivors have severe neurological insult or significant neurological insult. I think if this baby was born in a center that couldn't get him on a hemofilter quickly, and he had to be transferred to an intensive care center from a region, he may have had a very different outcome. So moving on to children who present with seizures and epileptic encephalopathy. So there are many metabolic conditions that can cause seizures, and clearly many non-metabolic conditions that can cause seizures. You won't be able to read these, but that's certainly a whole selection of them. So partly the question is, in a child presenting with seizures, what makes it more likely that they have a metabolic condition driving this? And they're not easy to pick up and diagnose. The first big thing is that these children who have metabolic seizures often have refractory seizures. So these are seizures that do not respond to standard treatment with anti-epileptics. There may be other things going on which help pick these children up. Certainly think about children who have multi-system involvement. So if this is a child who doesn't have a good history of HIE, for instance, so doesn't have a secondary cause of multi-system problems, do they have liver dysfunction? Do they have a cardiomyopathy? And certainly many mitochondrial disorders that present early on can present with this multi-system approach and seizures. Raised lactate. Again, there are many reasons a neonate will have raised lactate. If you have a seizing neonate that seems to have a persistently raised lactate out of keeping of sepsis or HIE, then again, that's a flag for something metabolic, both mitochondrial and energy disorders, but also some of our vitamin B6 responsive epilepsies. And that is one thing I will talk about in our next slide. Dysmorphism is also something to think about. Most of our metabolic conditions do not cause dysmorphism. There are some selective ones that do, and in particular, the peroxisomal disorders can present in the neonatal period with quite striking dysmorphic features. They have wide fontanelle, high foreheads, they have liver dysfunction, and very challenging seizures. So dysphortism can also be a key. So the main conditions or set of conditions I'm going to talk about briefly are vitamin B6 responsive epilepsies, because this is, unlike most conditions causing seizures in the neonates, this has very good treatment or very responsive to treatment. So vitamin B6 is important in many hundreds of cellular reactions in the body. In particular, it's important in how the brain makes neurotransmitters. So you can see here this PLP, or pyridoxal phosphate, is the active form of B6 and is essential in how we make GABA, dopamine, and serotonin. And there are a number of genetic conditions that affect B6. The classic one is called pyridoxine-dependent epilepsy, also known as antiquatin deficiency. This is a condition that's a defect in how the body breaks down the amino acid lysine. It essentially causes a toxic metabolite to build up that reacts with B6 and knocks it out. So it causes a secondary B6 deficiency. And these children tend to present very specifically with early onset refractory seizures. Another condition that affects the B6 pathway is called PMPO deficiency. This is a condition where the body can absorb and get pyridoxine or B6 to the brain, but it can't make the active form of it. And again, this will present similarly to PDE with early onset seizures, but often has some more systemic side effects as well. These children often have a persistently high lactate. They often have IUGR, they're born premature, and they can have bone marrow and liver involvement too. And the key thing is, if you're dealing with a child who have a refractory epilepsy, think about giving B6 as a trial, okay? Some of these children, well, these conditions we've been talking about don't have any reliable biochemical markers to diagnose them. Giving B6 is both potentially therapeutic, but also diagnostic. So for PDE, for instance, the most common form, pyridoxine rapidly improves seizures. It's generally recommended to give an IV bolus while you clinically assess the child, but also monitor an EEG, because seizures can stop almost instantaneously when this happens. Some children take a little bit longer to respond, but classically they respond very quickly. But a word of caution, if these children generally have a B6 deficiency, they sometimes can stop breathing when you give them the pyridoxine. So just be aware that if these children aren't already on a ventilator, that is important to consider. What is also important to consider is pyridoxine isn't the treatment for all of these conditions, in particular PMPO. So we've already said PMPO, you can't make the active form, so you can't use the pyridoxine. So instead, if pyridoxine is not, if a baby doesn't respond to pyridoxine, it's important to try some pyridoxal phosphate, which is the active form, which we can generally only get in an oral form, but again, it can have the same effect if this is PMPO deficiency, a rapid improvement of seizures and also the lactate. I'm rapidly running short on time, so I've got two more conditions. I'm just going to go over the really salient points. So NKH, or non-ketotic hyperglycinemia, is a really interesting condition. It's where the body cannot break down and get rid of glycine. So these babies are born with high levels of glycine in blood, CSF, and urine, and they have quite a defined clinical picture. These babies have often been seizing in utero, so parents, mums can give a history of hiccups in utero, and they're born floppy but seizing. And after a day or two, they will generally become apneic and require ventilation. If they're then ventilated further for a few days, they will often then develop their own respiratory drive and survive in the long term. The outcome for these children, though, is generally awful. They rarely show any development. They have very difficult to control seizures, and they remain very, very irritable and often die within the first decade. So I won't go through this in detail. It's a very interesting paper for anyone interested thinking about the ethics of this. But essentially, if you can recognize and diagnose this early, it allows a window of opportunity to give to families for the discussion about whether children can have care redirected or withdrawn before they can have their own respiratory drive. And the key to diagnosing this quickly is by measuring not glycine in blood, because that's not very specific. These guys will have high glycine, but you need to do a paired plasma and CSF glycine, and a high ratio is specific for this condition. The last condition, as I mentioned very briefly, malignant cofactor deficiency. This is interesting because it is a common HIE mimic. So this is our metabolic HIE mimic. These children are born, they seize very quickly, they have these swollen cytotoxic brains, which then become cystic and look very like HIE, and are often misdiagnosed. The key thing is, if you've got a baby who looks like an HIE baby, they may not have multi-system, multi-organ failure, which you might get in HIE. And if they don't have a history of HIE, think about malignant cofactor deficiency. There is a treatment for this now, which isn't very effective. And actually, the important thing about diagnosing these really is for future family. I've got one very brief slide on hypoglycemia, and it is essentially brief because metabolic conditions are rarely the cause of hypoglycemia in the neonatal period. Much more common hyperinsulinism, especially transient hyperinsulinism, other secondary causes such as extreme prematurity and sepsis. The conditions we do like to consider are the fat oxidation defects, which we've talked about already, and these children are generally very sick. They've got liver involvement, they've got a lactic acidosis. It kind of fits. If you're getting hypoglycemia, recurrent hypoglycemia in a relatively well child, then the things we need to think about from a metabolic point of view are the disorders of glucose metabolism. And again, most of these conditions don't present till later because you need to fast for a relatively long time. The one of particular interest is our one called glycogen storage disease type 1, because this can have a very short fasting tolerance, as little as 90 minutes. So these children will typically be well. They will go, if they're 3 hourly fed, they'll be dropping their blood sugars before a feed. And importantly, they will have high lactates when their blood sugar drops. So if you do a post-feed, blood glucose and lactate, relatively normal. A pre-feed will have low glucose and high lactate. So make sure, especially if you're considering hyperinsulinism, if it's recurrent, then make sure you do a pre-feed lactate. Because if it's a high, you might actually be dealing with one of these disorders. So my last slide, how we rapidly diagnose metabolic disease. As I've already mentioned, the key thing is recognition. And, you know, if we're thinking metabolic, talk to the metabolic team, and we can make sure we're rapidly measuring diagnostic metabolites that are important. If it's ammonia, anyone can get that measured, always think ammonia. But for other things like MSUD, for leucine, for fat oxidation disorders, for some organic acidemias, we can essentially measure metabolites from a small amount of blood. We're very lucky at the Evelina. We have a research lab that has developed something that we call the multiplex. So this is where they can take, it says 10 millimoles of plasma, sorry, so 10 microliters of plasma, so a very small amount. They can measure over 100 metabolites at once, and they can get an answer in around 10 minutes. So the reality is that if we have a sick neonate on the neonatal unit or our pediatric intensive care unit, we can grab a sample, we can take it to them, and we can sometimes have a diagnosis very quickly. We're trying to move this into our routine labs currently, which is challenging, but I think a lot of centers do have access to some forms of research labs that can do these very quickly, but often clinical labs cannot turn this around quickly. So this is a real valuable thing to have. The other thing is genetics, which has obviously changed massively. In the UK, the way we do genetic testing has been completely reconfigured in the last few years. Whole genome sequencing is available, but generally it takes 12 months plus to get a result back currently. Obviously not helpful in the acute setting in the neonatal unit. What we do have is access to a bespoke agnostic genome, which has a 2-week turnaround. So if we can justify that a child who's very sick, who might have a genetic condition that might change the outcome or management, then we can get this agreed in 2 weeks. But I'm aware that other centers and other research groups have done that sort of testing much more quickly within even 24 or 72 hours. So thank you for listening. I don't have a big conclusion. I've talked at you lots and very fast, and I hope it's picked out some of the key things to think metabolic for sick children. And I think the key thing is, if you thought metabolic, measure an ammonia, talk to your metabolic team. So thank you.